Good morning and welcome to today's webcast, Improving Cost Containment for Self-Funded Health Plans. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm pleased to introduce today's presenters. William Norris, partner at Healthcare Consulting. Will has been in healthcare consulting since 1991 and focuses on managed care and provider operations in payer, insurer, medical group, and IPA environments. He has extensive experience working within the operational infrastructure of managed care organizations on areas such as claims processing, utilization and referrals management, eligibility, and contracting. Francis Orejudos, Senior Manager. Francis has worked in the healthcare industry since 2003. He has experience with all types of managed care organizations, including HMOs, delegated IPAs, and health plans. Francis provides operational advisory services for regional and national Medicare and Medicaid plans, specifically related to claims auditing, revenue recovery, contracting, and business process redesign. He also consults with self-funded employers on managing their healthcare expenses through various cost containment strategies. And finally, Jack London, President and CEO and founder of London Medical Management and PatientPal.org. Since 1995, PatientPal has become one of the nation's leading patient advocacy services, helping over 3 million members across the country. London Medical Management specialized in large claim negotiations, wellness plan development and coaching, provider network analysis, and building and managing proprietary networks. And with that, I'll turn it over to Will to get us started.
Thank you, Emily, and good morning, everyone. Thanks for joining us today. We're excited to be speaking with you and looking forward to our session. We're going to get things underway by summarizing our learning objectives, and which will really serve as our agenda as well. We're going to start out by defining self-funding and the implications that self-funding has to employers. We're going to talk about some of the risks to self-insured employers as it relates to both provider billing and claims process. We're going to understand some of the different types of medical claim reviews that are available to self-insured employers and which really serve as strategies to help mitigate risk in a self-insured environment. We're going to identify some of the typical errors that we normally see when we perform our claims reviews, and these errors are in both provider billing and in the claims process, and they really are where there is exposure for employers. We're going to talk about why medical necessity and treatment of care guidelines should be reviewed. It's not enough just to do your typical high-level claim audit. There really needs to be some deeper dive drill down. We're going to go into that. And then we're going to end on talking about really, kind of the future and what are some effective benefit plan administration strategies. We'll end with that. So we've got a full agenda. We'd like to get a gauge of who is in our audience. So we're going to start out with a polling question. I believe at last count we had about 260 folks signed up for this, but we'd like to get a sense for the composition. So we could put up the polling question.
All right. Our first polling question. Where are you focused on your day-to-day operations? And your options are A, Human Resources, B, Finance Department, C, Plan Administrative Committee, tasked with fiduciary governance, C, a combination or mixture of the above, or E, other. I'll give everyone a few moments to respond. To participate in our polling questions today, please click the button next to the answer you choose and hit submit. I'll give everyone a few more seconds here. And let's go ahead and take a look at the results. Will, back to you.
Thanks. Well, thank you. It looks like we predominantly have folks from the finance area, which we would expect, but obviously we have a cross-section with some human resources folks, and I'm confident that in our presentation today we'll have something for everyone on the call today. So continuing on, let's as a starting point, I'd like to give a little bit of a primer on self-funding. I realize that many of you on the call are familiar with self-funding and being self-insured, but there may be those who are new to the game or just contemplating going self-funding. So self-funding is an arrangement where the employer assumes the financial risk for providing healthcare benefits to its employees. Said in another way, it's an alternative means for financing group medical benefit program, moving away from a fully insured environment to one, as the name implies, that's more self-insured. And a key element in this arrangement is that employers pay for claims as they are presented instead of paying a premium to an insurance carrier. So they're essentially paying for services on more of a dollar-for-dollar basis, and it's a direct cost that actually, and it's what we're talking about today, that needs to be hands-on managed. So going to the next page here, there are certainly many, many positives to be realized by going self-funding, going the self-funded route. And we see that. We see more and more employers moving in this direction, even the smaller employers. And there's a lot of reasons for that. Self-funding allows employers to reduce administrative fixed expenses. Well, said another way, those fixed expenses really are in the form of health plan profit, health plan margin. So those go away, of course, and the self-funded employer is able to retain cash until employee claims are actually paid or funded. So two big advantages there, and there's a lot of estimates that are out there as far as what those savings actually equate to. Some of the ones that we've kind of gravitated towards, there's an administrative savings in the neighborhood of 9% of insured premium. Again, there's depending on which source you go to, that number may change. Then there's also, as I mentioned, the cash flow savings. Since there is no upfront premium being expended and medical expenses are happening as they incur, there's savings in that regard as well, to the tune of about 20% of the insured premium. One last thing I want to talk about as part of the self-funding primer is when employers go this route, they typically engage the services of a third-party administrator to operate the plan. That's because they are not in the claims business. They're not a payer, so it makes sense for them to outsource this function. But it's with that there lies some of the risks that we'll be talking to in the coming pages. So I mentioned clearly there are positives towards being self-insured, but there's also risks to that. There's implications of self-funding, and let's talk a bit about that before we jump right into the meat of things. Stating the obvious, the employer here is bearing 100% of the financial risk. I mentioned it, on a dollar-for-dollar basis. And as I said earlier, that part of the equation is that claims are outsourced to a third-party administrator. And as they should be outsourced, but I will tell you, claims is a very complicated business. It's what we live in and day out. And the error rates are significant and substantial. Error rates range in the neighborhood of 2 to 6% for the typical payer out there. Some estimates are much larger than that. And you ask, why is that? Why is there such a big error rate? Well, in large part, it's because the typical payer focuses most of their attention on regulatory and compliance issues. That's what they're getting graded on a lot of the time, and so they're focused on that and not as much on the accuracy of claim payments. And in a lot of TPA situations, they do not have financial accountability. It's not their dollar, and so the incentives aren't aligned, and they see it more as a transaction. So that's why some of those error rates are as high as they are. And one last thing I want to mention, in a lot of third-party administrator agreements, employers may try and protect themselves with performance guarantees or performance standards, and that is good, certainly. But I will tell you, in measuring against those performance guarantees, the third-party administrator typically self-reports their results, so you're not getting a really objective and reliable grade, if you will. And even if there are, grades that are being provided, typically in performance guarantee, there's no downside risk. So there's not a lot of teeth to a lot of performance guarantees that we see out there. So those are just some of the risks as it relates to self-funding. So now that I've laid that out, I'm going to pass it along to Francis Orejudos, who's going to talk more about the strategies associated with self-insurance.
Thanks, Will. So as you're talking about the risks of self-insuring and delegating your claims administration to a third party, we see audits of the claims being processed by the TPA that audits should be considered. So for plan sponsors and employers, they have a fiduciary responsibility. Being self-insured, plan sponsors are at risk for medical claims liability, and they have a legal obligation to monitor this liability. And a claim review, a claim audit, they essentially act as an appropriate control for monitoring and measuring the liability, and monitoring specifically how claims are processed by the TPA. Sometimes we hear that plan sponsors have a SOC 1 report for their TPA, which is great, but it's helpful to understand that a SOC 1, what it does is it tests controls or procedures. It tests qualitative processes at the TPA, but it does not include testing of actual claims transactions. And only through actual claims testing can you really determine the performance of an administrator. So we see audits are sound best practice or business practice. They're sound business practice. So we hear many plan sponsors go on autopilot. We were just on the phone yesterday with a plan sponsor how they have about a $12 million medical claim expense, but they've been letting it go on autopilot for a couple years once they went self-insured. And you want to go on autopilot. You want to have a trusted partner as your TPA. It makes sense. There's a reason why you went with your TPA in the first place. But it also makes sense to perform audits of the plan just to make sure it's operating well and that there's no unnecessary claims expenses happening. Also, plan sponsors, it's worth considering audits because it helps to maintain, plan assets and make sure that they're protected. As we talked about, just, with leakage having to do with administration of the plan, you want to make sure that's minimized as much as possible. And as you monitor your TPA, you want to make sure they're meeting best practices in their administration. TPAs, if they are high performers, they are measuring themselves regularly, consistently against industry standards involving claims processing metrics and timeliness metrics. And audits just help to ensure that is happening as well. Now, and it might sound too that the last thing that your TPA wants is to be audited. And we're here to say that that's not necessarily true. The high-performing ones we've worked with over the years, they support audits. I know it's surprising, right? But it's because they see audits as another opportunity to learn about their defects or issues in the process as they try to improve. They just want to get better. They want to increase their performance. And in that way, audits help to build trust. And as counterintuitive as it is, that sounds, the best TPAs want to be audited. And I'm just thinking for ourselves too in our firm right now, we're going through talent review, and the best performing people on our team, they're the ones who are coming up and asking for feedback, and they want to learn what they're doing wrong so that they can get better. And that's along the same vein, right? Your partner, if they're a high performer, they want more feedback, they want more opportunities to remediate on issues that are happening in the plan. So with that, I think we have our next polling question. So Emily?
All right, our second polling question. How far back does your TPA allow you to review claims paid under your medical plan? And your options are A, there is no limitation, B, 1 year, C, 2 years, or D, I don't know. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. If you have any difficulty seeing the polling question today, you might try refreshing your browser with F5. We'll give everybody a couple more seconds. And let's go ahead and take a look at the results. Francis, back to you.
Great. So it looks like we have a pretty broad, for the ones that do know, we have some broad responses, whether there is no limitation, whether there's a 1 year limitation or 2 years. And for those of you who don't know, appreciate the honesty, and just as by way of determining that, it's in your administrative services agreement, and there should be clarity there around the limitations. So just moving on here. So the types of claim audits, that are offered. So, we talked about audits. What do they look like? What's involved? And, claim audits, as you can imagine, it is just really about identifying the performance or measuring the performance of a claim administrator. And it involves identifying where they're, paying claims incorrectly and testing their accuracy. And it's around the actual claims transaction. So when we talk about auditing a TPA, we're talking about when their claim is received all the way through payment. And we outline some audits here and just talk about them at a very high level. But random sampling, that's the most common type of review. It involves taking claims from a certain period and making selections for testing. This is the most common. And we see government entities, this is how they test claims for regulatory purposes for plans across the country. And we see it is the only valid way to assess the performance of the TPA because it's based on statistical factors related to confidence levels and precision. So it's the most recommended, and we see it's the most comprehensive as it also entails having system access and testing in the same conditions as the claims when they were originally processed. Pre-implementation reviews, these are most common, these are usually done when new plans are installed at an administrator. It involves testing 10 to 20 dummy claims or test claim scenarios in a read-only test environment to make sure that a system is designed and configured properly. Focus reviews, this happens when you have an inference for specific issues with the administrator, whether it's plan benefits, if there's known issues. Oftentimes, we hear that plan sponsors hear from their own members about complaints by how claims are processed. So that's when a focused review might take place. Electronic reviews, These involve taking claims and from a period of time and using query applications like SQL to mine data and identify payment errors. This is much broader than a random sample in that it covers more claims for testing. But also, on one hand, it's more shallow in that standard claim data can be limited at times in providing all the information that's needed about a claim, and data files often miss nuances in a claims transaction, such as medical documentation or provider contract provisions that can significantly affect the way a claim is paid. It's also worth noting, we've been talking about medical claim audits. For pharmacy claim audits, they specifically only are conducted via electronic audits. That tends to be the norm since all the necessary data for a pharmacy claims transaction can be provided electronically. So that's just something worth noting. And what we've seen is that most PBMs don't even allow for random sampling or on-site testing. So just something worth noting there around claim audits. And we're going to go forward here. Oftentimes we're asked, what are the types of things that you see in claim audits? And at a high level, we cover some errors here. Duplicate claims. This really has to do with the lack of system integrity at an administrator. Oftentimes, provider tables have a lot of junk. A lot of provider IDs are entered and are not tracked properly, and that could result in multiple claims being paid for the same episode. Contract issues, contract rates being applied incorrectly, and it's often due to changing rate tables and even miscommunication between the departments that set the rates, which is in provider contract relations or provider network management. Sometimes there is miscommunication between them and claims processing. So we see oftentimes errors related to contract rates. Cost sharing, we know that plan benefits change frequently, and with those changes, there's opportunities for errors, especially in tiered benefit structures. That could be challenging to manage. So cost sharing typically is one of our most common errors that we identify in our reviews. We'll go forward here and talk about a case study. Here, this kind of distills what we've talked about with claim audits, and this is for a medical claim audit where a few years ago there was a large employer in the Northwest where they had a $14 million claims expense, and they changed their TPA. And you see here that we list their client service level agreement and what they reported for their own results. And if you see there in the middle, our project result, it was below both the self-reported results and the client service agreements. I mean, that was below in all accuracy measures. So from a claim audit, we're able to see that our testing was below what the TPA reported for themselves and below what they agreed to for their administrative agreement. And also you could see the size, the magnitude of the overpayments we're able to identify. And for this particular review, it was because of the contract rates that were not being applied correctly. So it yielded a significant amount of overpayments for this particular plan. So with that, I think we have our next polling question, and it has to do with what you've last observed in your own audits.
All right. Our third polling question. From your last audit, what was the dollar amount of claims errors and overbilling observed? Your options are A, under $10,000, B, $10,000 to $49,999, C, $50,000 to $99,999, or D, over $100,000. And for those of you that would like a copy of today's slide deck, you can download them now from the folder that says Slide Deck and Handouts to the right of the slide view. We will also be sending the slides and recording via email after the webcast. And just a few more seconds here. And let's go ahead and take a look at the results. Back to you.
Great. Well, it looks like for those that reported back, the majority of you have had a review done and that the results were under $10,000, which sounds great. And it sounds like, and that's what we often find too in our claim audits, that, there is a possibility for errors. But at the same time, from our reviews, we're also able to identify that many TPAs are performing well in accordance with how plan benefits should be administered. So that's a commendation. And for those that were able to report here, it sounds like you do have a strong business partner processing your claims. So good for you. So with this, I think we're going to move on from our discussion about claim audits. And we're going to introduce Jack London, and he's going to talk about another component of the claims process. As I mentioned with claim audits, in our auditing, we look at the claims transaction once it's received from the TPA all the way through the payment. And Jack's going to talk a little bit about the provider billing and how there's a nuance there and there's an opportunity for risk with how claims are billed from the providers themselves. So, Jack?
Thanks, Francis. Hello, everyone. As Francis pointed out, this is kind of an interesting scenario in the fact that itemized billing is not a common scenario when a bill is submitted to a third-party payer for payment, meaning that there's not a line item of services that are allocated towards the cost of that particular claim. It's just basically either a global payment, a DRG, which is known as a diagnostically related group, which is a grouper payment. And what we're looking for, the medical necessity of services, and then also the duplication of billings of items in that, and then, of course, utilizing industry standards of the coverage that are applied. So in that, what we are desiring to do is to find possibility of overbilling, duplication of billing, and other services that have been provided that may not be medically necessary. So we look at the provider billing to the medical records. This is important. And this is when we're doing a line item of a bill and we're reviewing the medical records that coincides with that specific service that's being provided. A little bit later on, we're going to be able to show you the case in point of services that were rendered, or at least billed, but were never rendered. So how are these documents reviewed? We are dealing with one claim at a time, clearly. We're dealing with the medical record to verify the services. We're looking at the treatment of care standards, and that would be a diagnosis specific, utilizing the medical guidelines. I believe we have a polling question, Emily, now, and I'll let you handle that one, and then we'll pick it up.
All right, our next polling question. For claims processed for my medical plan, what percentage of claims have itemized billing when sent to the TPA? And your options are A, less than 5%, B, 50%, C, 75%, D, 95%, or E, I don't know. And once you have completed all CPE requirements, you'll be able to download a PDF of your CPE certificate from the certification widget to the right of the slide view. I'll give everyone a few more seconds. And let's go ahead and take a look at the results. Jack, back to you.
And that's understandable and not knowing. And here's the interesting fact there. Thank you, Emily. As I had mentioned previously, the itemized billing is usually a requested aspect of a bill. So when a bill is presented to your third-party payer, it's presented in total for the amount of days possibly that that patient was either inpatient or it was an outpatient procedure. And then, of course, there's a dollar amount attached to it. Very rarely do you see an opportunity of itemization of services. And as a result, those duplication of services, when we're looking at these itemizations, come into play. They may have an incorrect CPT code, which is the parameter by which a claim is billed and reimbursed. There have been services that are now billed that have never been performed, even though they may be part of the billing. They have charged for materials, pharmaceuticals, implants, other situations that were not part of that particular claim. And then, of course, on the unjustified charges for implants. On a side note, if you're talking about a prosthetic, let's talk about hip replacement, for example. On a hip replacement, you're charged for the implant. Most contracts that are in place prior to your third-party payer paying them are usually an all-inclusive rate or some bundled or all-inclusive type of case rate for hip replacement, for example, that includes the implant. For those that do not have a bundled payment or a case rate for that, most hospitals charge almost 10 times the cost of the implant. So if the implant is $6,000 in cost, you can pretty well bet that your cost will be $60,000 for that specific implant. I do know that a majority of managed care plans like to do a cost plus within the parameters of their contract with a facility, a provider who's providing that type of service. So it would be, for example, the cost of the implant, which has to be itemized and proven, whatever that is, with the point of record of $6,000, and they'll pay them 10% or 20% above the cost of that implant. Those are some of the things that we look for in our billing reviews. I'm going to give you a case study about a very large claim, but unfortunately it's becoming more of a standard in these large dollar claims. As you know, since the Affordable Health Care Act, there are no more limitations to your plan, where it used to be a possibility you could have in there a maximum exposure of $1 million. Well, that's no longer the case. We've seen claims of $5, $6, and $7 million range. In this case, the member gave birth to a premature baby who was admitted to a NICU, or neonatal intensive care unit, and the mother needed stabilization. So you have two claims, and they separate those claims. It's not billed collaboratively between the mom and the baby, but they're separate claims. Well, here's an interesting aspect to it all. When we were able and asked for a line item audit to be able to look at an itemized claim for that service, now keep in mind this was a preemie baby. This infant was charged for occupational therapy, for speech pathology, and speech therapy. Obviously, those are claimants that were charged that were never rendered, nor would they be medical necessity. But we were able to unearth that in the line item audit. Prior to that, when the claim was submitted, it did not provide the line item services that were billed back. So when we requested that, we were able to unearth these types of situations. Unfortunately, folks, this is very standard in our industry today. The other aspect of it all was the way that the billing actually took place. If you'll notice here, if you can see on the NICU nursery level, they're itemizing several days. The third column, or the second column over, are the amount of days the baby was in the NICU. But they had stated also that the way that their system works, they couldn't bill over a $100,000 number. And that's why all of these bills are at $99,000 for the most part. So it was a multiple of services that were provided in a billed arena that should have been extrapolated into an individual level of service. And there again was an opportunity for savings on our end, which we did find. We also asked for the vaccine that were specific. All it stated was, and you'll notice in this line item, was there was a $130 charge. Now, granted, we're talking about $1.5 million in billed charges, $1.5 million in billed charges. And I'll go on further to tell you that the actual discount off of billed charges was part of the reimbursement for this claim. So what is happening? What's happening is the fact that today, instead of a case rate for a preemie baby, there isn't really any that we've seen, that child could be in the hospital for 3 months, 5 months, 6 months, a year and a half. And at the end of the day, the reimbursement back to the hospital is a percentage off of bill charges. That is a very egregious amount. And in this particular case, you can see even in respiratory services, which we were able to outline, they once again hit that level at the $99,000 rate and kept providing respiratory services, it seemed, ad infinitum. So we are looking at these types of charges and circumstances that come up in order to bring cost savings to a plan. So what we came back with was we separated the baby's claim. We had the mom's claim, which was bundled, which we in turn denied. We requested a detailed bill to be able to determine what the hospital was charging for that vaccine of $8,000 once again. In the lab, they noticed the general class in the lab, there was no itemization in the lab, so we asked, we need a detailed reasoning for you to charge us $12,000 worth of lab, which you have subsequently charged, as you can see, on the various other line items. So these are all details that are extrapolated from a bill, and we in turn able to bring cost savings to the plan. What we were able to determine was there's a multiple of services that were billed that were wrong, as you saw with the speech therapy and the physical therapy for the child. Those were removed from the bill. And the mother, of course, had duplication of charges on her bills. And in each case, we were able to bill back to the hospital and seek a refund, since this bill was a post bill, by the way, where we prefer to receive these types of bills on a pended process. When a claim is on a pended process, it's set to be paid, but it is suspended until we have the opportunity to review that bill. And in this case, we would have been able to provide savings prior to the actual adjudication of the claim. In the case study of another case study, by the way, there was a member that received a bilateral mastectomy, but something was not right. It didn't seem that when the amount of billing was submitted, they actually submitted one bill, recanted that billing, and then sent another bill at considerably more. And the member is the one that actually picked up on this. Now, in the process of a claim, when it goes into the third-party payer, the payer is not to determine the medical necessity. The payer is not to determine the necessary reimbursement, because what they've preloaded into their system is already the contracted rate. So it's up to an organization such as ours to be able to look at these bills in the itemization process to determine indeed whether or not there is a challenge to that billing. What we were able to find was several levels of circumstances, one of which was there was a surgery level that they billed out, which we were able to deny because it was not administered in this dual mastectomy. And then there was a duplication of charges, and the duplications happened to be in a pharmaceutical that was administered to this patient, and they actually billed twice for that procedure, as well as for the pharmaceutical that was provided. Now, keep in mind, here is a bill that surfaced as a result of a suspicion, not necessarily because of the type of procedure that was done, but because of the cost of that particular procedure. So in this case, what we looked at was the fact that the total billed all the way through was $225,000, but we were not able to, from the medical records and from the physician's notes, find that the procedure was performed. It was a hospital billing area. Secondly, we found that there was another 2 services that were provided, or at least billed for, that were never provided. And then within the parameters of the CPT code, which was to be billed internally for this particular claim, it did not match in what was allowed. So in our summation, we were able to come up with a $90,000 savings on this one claim. That's one claim. So you can see where the opportunity exists that these types of situations occur, and unfortunately occur frequently. So here's what we were able to conclude. There was significant duplication of billings for surgery time. You can't bill twice for the same procedure. The supplies, as I had mentioned, that were reportedly administered were not billed appropriately because one of the supplies that they had billed for were never administered, and $87,000 should not have been paid, which it was, by the way, because it was the way that it was structured in the payer process with the claim. With that, we know that coming forward in cost containment, there are opportunities for now direct contracting, something that we'll be subsequently discussing at a later date and time. But with the medical claim audits and the billing reviews, we have an opportunity, obviously, to identify some cost savings. And these cost savings are done retrospectively. As Will and Francis have pointed out, between the audit and the line item billing and the opportunity to be able to bring to fruition some potential savings. And we're not pointing fingers and basically saying that your TPA is not doing their job. The issue is that the hospitals are overbilling at times. Circumstances of itemization have not been required. There's, in fact, several large health plans that are not requiring itemized billing. And the case in point that we were able to share is the reason that we believe that needs to occur. So going forward, we know that opportunities now are direct with hospitals as a self-funded organization, with as a majority of you are today. The opportunity exists where you can have a literally direct relationship with a hospital or hospital system within your geographic area that will not only bring cost savings, but will bring a higher level of engagement to your patients, to your employees, to the members of your plan, and at the same time bring transparency and education to have them understand the cost of medicine and where we're at. And with that, we move along for Will to provide the summary.
Great. Thanks, Jack. And we've covered a lot. And before we jump into questions, and there's been quite a few questions that have come across, we just want to kind of recap what we've gone through. Like I said, we've covered a lot of ground here. So number one here, self-funding allows employers to save significantly. We've proven that, and on their healthcare spend. Yet there are inherent risks. And I guess the key theme to take away is employers who have gone self-insured should be actively engaged and managing their arrangement to maximize the outcomes. I earlier on talked about the savings that are available to those employers who go self-insured. Well, those savings will not be realized if there isn't hands-on management with the self-insured arrangement. And like Francis mentioned, all too often we see these self-insured organizations kind of put the whole program on autopilot and trust the third-party administrator and just really kind of, they detach themselves. And with that, they're not maximizing the outcomes. We were talking yesterday with a gentleman, and he was talking about a client of his. They have a $12 million healthcare spend that Francis had even referenced. And the CFO was asked, how important is that $12 million in your overall scheme of things? And he said, extremely. And then he was asked, well, how many hours during the course of a year do you spend and before the question was even asked, he said, it's not hours. We spend minutes really strategizing on our healthcare spend. And I think that's not too uncommon. That there's, once you go self-insured, you think the savings are automatically going to lock in. They do not, and it takes very, very active hands-on management. We often say that self-insured healthcare spend is one of the highest unaudited costs on financial statements that we see, and obviously we're from an accounting firm, so it definitely warrants that view. Medical claim audits, as Francis mentioned, it's an effective strategy, one of many in identifying savings. It's a means for cost containment by identifying the accuracy of claims processed by the administrator. And at the end of the day, for those on the call who are self-insured, it's your means for ensuring that you're getting what you expect from your administrator by putting some metrics and benchmarks to how well they're performing. Jack talked about provider billing reviews, and it yet represents another means for an employer to discover claim overpayments, by finding services and items that are incorrectly billed by the providers. Claim audits, we talked about, they're auditing what's received to make sure it's processed correctly. Billing reviews go more upstream, really look at what's being billed, and the errors that happen on the processing side are equaled by what happens as far as billing errors upstream for providers. It just, you have to have that combined look to really maximize the outcomes in a self-insured environment. And then lastly, Jack was talking about, the next wave, what's coming down, and we see it definitely, and we're all hearing about it in the news, kind of the new frontier of organizations, maybe moving to self-funding, but then maybe also looking at direct contracting as another means for cost containment. So that's definitely out there. I know many groups are not there yet, but we're hearing about it in the news all the time with Amazon and whatnot. So it's kind of the next wave.
So thanks, Will. And just to your point about direct contracting, we chose to have that last portion in our presentation because we plan this year to have an additional webcast like this. So we're seeding that piece now for our next webcast. So just an FYI for those who've attended. So we have plenty of questions here. Thank you so much for all those who submitted their questions, and we're going to take the remainder of our time to address those. So I'm going to start here with one question, and this is for you, Jack, as it pertains to the provider billing review. So it seems like with the review of the provider bill, it requires access to very detailed information, especially about an employee, and it could potentially place the employer in an awkward position when making decisions about the employee, their health status, the payment of their medical coverage. This can be perceived as, well, not perceived, this is actual very intimate information about an employee. How is this addressed? How do you see that addressing that, Jack?
It's a great question. Well, first off, these are HIPAA-compliant situations where there is a confidentiality that has to occur in the aspect of this. We're talking about the claim, the payment, the billing, and that is between the hospital and the plan. And we're not trying to implicate nor discuss the patient's involvement in it other than the fact that they were the patient. So when we are going through this line item audit of services, we are looking at a hospital that's providing services to a patient. And keep in mind, every hospitalization has an itemized bill that's available to you, the patient, as well as to the plan. But it's available in a HIPAA-compliant form. So in this case, it was patient-specific. However, we were talking about the procedure and not necessarily any confidential information that would be skewed outside of that audit process. It would not compromise the level of confidentiality to the employer. It would merely say into the audit process, we are asking for a itemization. We're asking for a line item of services that were provided, and every contract is different. The interesting aspect today is that when you have a hospital agreement between let's say a carrier, the third-party payer is administering that contractual agreement with that hospital, that TPA is paying whatever that agreement is with the hospital. Well, that's fine if there are case rates and there are specific per diems, which are all-inclusive rates that are being reimbursed. But when you're talking about a reimbursement at a percentage off of billed charges, every hospital's charge master is different. And what we're doing basically is looking at the claim and the line item of services. So when it comes to confidentiality, that's internal. And it's about information that is kept confidential, and guidelines of HIPAA are met. So I hope that answers that question.
Great, Jack. I have another one for you. It says, for those of us covered under group plans and Medicare, should we demand that we see details of hospital and provider bills, which we almost never see? We only see a summary billing that reflects what the insurer has paid and the balance due from the patient. How would you address that, Jack?
The challenge that is faced is that if you're utilizing I go back to the carrier, and let's say, for example, you ask them what kind of billing and what kind of negotiated arrangement do you have with that hospital, their response to you is going to be, I can't tell you that, it's proprietary. Well, that's the challenge that we are dealing with every day. That to me is tantamount of purchasing an automobile, not knowing how much you're paying for it until you have it in the driveway and they send you a bill. That's basically what's happening. In the case of asking for line items of itemization, itemization is granted. They cannot withhold an itemization for you if you ask for that billing. So if there's a suspicion that a bill is out of the ordinary, but how does the individual know? Sadly, we use, if it's an analogy at all, that we know of a group that has a specific carrier, and they're paying for colonoscopy services on one spectrum as little as $400. Oh, granted, this is the same procedure, $400, and within the same plan, they're paying up to $4,000 for that colonoscopy. So how do you know the difference? Well, that's when you ask for those services and try to have a fully transparent opportunity. I think it's a challenge, and it's a challenge that you all face, and we will continue to see that challenge.
Thanks, Jack. Again, we have many questions, so we have a limited time, and we're going to try to get through as many as we can with the few minutes we have left. So here are a couple of quick ones. I think this goes back to Will's discussion about claim audits, because error rates were referenced, and the question is, are error rates a percentage of claims, the quantity of claims or claim dollars? And the answer is both. So if you're looking for error rates, they're presented in both views, incidence of claims or quantity of claims, and that's defined, you could see that as claims processing accuracy or claims payment accuracy. You'll use that metric to identify the incidence of claims paid correctly, and then also claims dollars. That is financial accuracy. And I know it's not part of the question, but just for the audience, the industry standards for those, we can share that from what we've observed. And we also see this with regulators as well. But the industry standard for claims dollars being paid correctly, 99%. So you should look for that from your administrator. And then for claims processing accuracy, usually it's in the 97-98% range. So claims incidence accuracy, you're looking at 97 and 98%. So good question. Also, regarding the look back period, I think there was a comment, and it had to do with a polling question as well. What's the most common, whether it's between the 1 year, 2 year, or unlimited? And typically, we're seeing that most administrators have it in their audit provision a 1 year look back, and that you can imagine, right? Because you want to limit the number of claims that they'll be responsible for supporting in a review. More and more audit provisions are limiting the number of claims to 1 year, and also just even limiting the number of claims in a claims test as well. That wasn't mentioned in the webcast, but we're seeing more and more administrators limiting the sample sizes to be 300 claims, just for the audience, for your reference. So, good question there.
I'll just add to that. Not only are we seeing there be limitations on the number of claims to be audited, we're also seeing more and more limitations on the type of audit that can occur, in that it has to be a statistically valid sampling. There are other types of audits that occur that Francis mentioned out there, 100% electronic and some even targeted, but a trend that we're taking notice of is some of these RFPs or requests for these type of audits are very, very targeted and specific in as far as they want them to be a statistical sampling process. And with, as Francis mentioned, with an amount tagged to it, not to exceed, let's say, 250 claims. So definite, I guess, some of the administrators out there are getting more specific in how they want these things to go.
Great. And I think we have time for maybe a couple of more questions. Here's a question. How do I know what type of audits are allowed? And, again, that's something where in your administrative services agreement, and that's maybe a takeaway for many of you in the audience who have not reviewed your ASO agreement recently, if you are self-funded, is just take a look there. In there, there's a lot of detail related to what can be audited, the extent of what can be audited, and it pertains not only to standard claim audits, but also provider billing reviews. You'll see their language, whether provider billing reviews are permissible, or if there is language around limiting the extent and scope provider billing reviews as well. So a takeaway from this discussion could be just looking at your ASO agreement and seeing what's permissible under what you've agreed upon with your administrator. Another question I have here, and this is for you, Jack, and you may or may not have touched on it in the webcast, but just to expand on it more, as far as the typical procedures and episodes that you observe in your reviews, is there any one or any specific type of procedure that you see commonly misbilled?
Back surgery is I see a lot of extraneous charges for, and then anything that has to do with implants. So again, I go back to the hip replacement, knee replacement. Even when we talk about back surgery, we know that there's an awful lot of nuts, bolts, and screws that are in those particular areas. Those are the ones that come up most of the time, Francis. Great.
I also have another question around just the relationship between the TPAs in the claim administration. It sounds like the TPA might process claims, but rates are set through a national carrier. How do you audit rates at the TPA? And we'll respond to that. So in that situation, actually, you're not going to be able to audit rates at the TPA because the rates are set through a separate entity altogether. So an audit's only going to cover the scope of what the administrator is responsible for. And in that case, since they're not responsible for the rates, you're going to be auditing just the process. And part of that process will be the TPA receiving the rates and applying those rates to the claims. There would probably be a separate review done at the carrier about those rates and whether those are being actually calculated and set correctly for your claim? So that's a really good question, because we know that many of you have TPA relationships where they rely on a rental network or a lease network or another entity for the rates they receive for pricing your members' claims. So that's a really good question. So I think here, Emily, we're at the end of our time. So is there any last comments we have here from Will or Jack?
No, I just want to thank everyone for joining us today. We've appreciated the time to speak with you, and I think on some of these other questions that we haven't been able to get to, we'll definitely address them and get responses out to those who've asked. Yeah, again, a lot of good questions here. We only have a few we're able to answer, but definitely if you did submit a question, you can certainly expect us to respond very shortly and get back to you. So thank you for submitting them. And Jack, any last comments from you?
No, thank you very much, everybody. I know it's a complicated scenario being self-funded, and we did have several entities and questions in regards to the applicability of self-funding. We'll respond to those folks via email, I believe. So thanks so much for giving us the opportunity in this forum today.
All right, Emily?
All right. Thank you, Francis, and thank you, Jack and Will, for a great presentation today. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts icon to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate. A copy of your CPE certificate will be emailed within 2 weeks should you have any difficulty downloading it now. And here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.